Hello everyone. Let's review some helpful hints for diseases of the nervous system and sense organs. Let's begin our discussion today with the diagnosis of epilepsy. Most of you know that epilepsy is a condition that is often characterized by seizures. However, coders need to be careful with this diagnosis. Make no assumptions from the medical record just because seizures may be documented within the record. Coders should not assume that this means that a diagnosis of epilepsy is in order. There are other diagnoses out there that may cause seizures, so we can't assume that a seizure documented in the record means that the patient has epilepsy. So just like with AIDS, HIV, epilepsy cannot be coded unless the physician clearly states the diagnosis in the record. So again, like AIDS, there could be serious legal and personal implications for the patient if this diagnosis is mistakenly assigned. Often when coding for epilepsy, you will come across the term intractable. Well, what does that mean? Basically, intractable means that the condition is not easily managed. So some terms that you may commonly see in a medical record that signal an intractable condition are pharmacoresistant, resistant to drugs, poorly controlled, refractory, and treatment resistant. So if you see any of these phrases within the medical documentation, please know that they all equal or mean intractable, as that is usually going to be the subterm used for these epilepsy conditions. For example, in exercise 17.2 this week, we find the diagnosis of poorly controlled, generalized idiopathic epilepsy. So we will start in the alphabetic index for the condition, the epilepsy, find our subterm generalized, idiopathic, and then intractable, which leads us to code G40.319. Well, why do we code this as an intractable condition? Why did we use that subterm? So remember, again, on that previous screen, poorly controlled, that's one of those key phrases that you can find that tells you that this is an intractable condition. It doesn't respond well to treatment. It may be resistant to drugs. So again, all of these phrases meaning that it is an intractable condition. Now that we're here looking at this, I want you to notice G40.319, our generalized idiopathic intractable epilepsy. If you look down within these subterms, you will see with status epilepticus and without status epilepticus. Note that the without code is the same as our original code, the G4319, without status epilepticus. Well, what is status epilepticus? What does that mean? This phrase indicates that a seizure usually lasts longer than 5 minutes, or there is an occurrence of more than one seizure within a 5-minute time frame without the person returning to a normal or non-seizure state. So usually you will see the phrase status epilepticus documented within the record when it's necessary. If the phrase is not used within the documentation, then you know that status epilepticus is not the case and should not be coded. Moving past that epilepsy condition, in this chapter, you will also find coded many conditions relating around hemiplegia and hemiparesis. So paralyzed, 1/2, weakness, 1/2, right? Using that medical documentation. When coding for these conditions, you will often see referenced dominant and non-dominant side. So for example, if a patient is right-handed, and the right side of the body is affected, that would be their dominant side. Same with the left. The patient is left-handed. The left half is being affected by the hemiplegia. That would be the dominant side. However, what if the document doesn't state whether the patient is right or left-handed? Then how do we know how to code that dominant, non-dominant side? In the previous video this week, we reviewed chapter-specific coding guidelines. In that video, we reviewed a guideline about coding for non-dominant and dominant sides when things are not documented as such within the record. So again, go back. If you have not already looked at that chapter-specific coding guidelines video, go back, take a look, and remember that those chapter-specific coding guidelines should be looked at each week before you start coding for a new body system chapter. Now that we have a few helpful hints behind us, let's take a look at an exercise from this week's assignment, exercise 17.3. Here we have an example: severe chronic low back pain due to displaced lumbar disc with neuritis due to previous trauma. And then the procedure or service here, epidural injection of steroid for pain. From your reading this week, you will discover that an admission for an encounter for pain management or control can use a code from category G89 for chronic pain as the principal diagnosis. So here we see that the patient encounter is for the purpose of treatment for the chronic pain, because you do have this epidural injection of the steroids, which is the treatment for the pain management. So this is a clue as to the route we will take for this exercise. A little helpful hint, again, take time to read through your chapter-specific guidelines in the front of your book or in front of the nervous system chapter in the tabular. Maybe take a moment and pause the video right now and check out that nervous system guidelines list, as it does address the G89 category for chronic pain. You will find this very helpful, and it will also get you into the habit of checking the guidelines when you need a little direction during your coding. Now, since we do have an encounter for pain management, we will go ahead and begin with that category G89, that chronic pain code. We will begin in the alphabetic index with the main term of pain, subterm chronic, and then the other subterm to include here is due to trauma, right? Due to previous trauma based on our documentation. This leads us to code G89.21. We will check the tabular list, of course, and when you do, you will see that everything checks out okay here. Now we need to identify, since we have the pain due to trauma, we need to identify that specific trauma. It tells us that we have a previous trauma and we know it was concerning the displaced lumbar disc. So we will start in the alphabetic index with the main term of dislocation. There is a main term for displaced, but it usually doesn't lead you to where you need to go. So make a note to yourself that dislocation is always a good main term to check when you see displace documented within the record. So displace is just going to eventually lead you back to dislocation anyway. So dislocation, subterm vertebrae, sorry I covered it up there, but subterm vertebra, and under vertebra we have subterm lumbar, which leads us to S33101, and then we know we need to check the tabular list. And when we get there, we will pull in the 7th character S for sequela, which also means late effect. So here we have that dislocation or displaced vertebra, lumbar, S, sequela, late effect for that 7th character. So S33.101S. Now we have documented the chronic pain due to trauma. We've identified the trauma, And now we're going to code for the underlying conditions for everything, which is just the low back pain and the neuritis. So here we will go to the main term of pain again. Lumbar region, if you notice, it also has a subterm for low back. It's the same area, right? Lumbar region is that lower part of the vertebrae. So M54.5 will be our code here for the lumbar or low back pain. And you will check the tabular list, and that code will definitely check out there. Then we need to pull in the code for the neuritis. So we start with the main term of neuritis. Again, subterm lumbar, M54.16. Again, check the tabular. Turns out okay. At the end of the day, we have 4 diagnosis codes for this basically 2-line diagnosis statement. Now that we have our diagnosis codes, let's go ahead and code for that service or procedure, the epidural injection of the steroid for the pain. Remember back in chapter 10, we discussed medical and surgical related procedures. There we learned that services such as injections, infusions, or transfusions are coded to the administration section of the PCS codebook. So since we have an injection in our documentation, we have that epidural injection. This is considered an administration. So we're going to go to the main term in our PCS codebook, right? We're doing the procedure and service, so make sure you're in the PCS. Administration for our main term. And here you see you will have 2 options. Blood products, C transfusion, or other substance. C introduction of substance in or on. Well, we don't have the blood products. We don't have a transfusion going on. So we are going to go where it tells us to go. Introduction of substance in or on. So we're still in the alphabetic index here. Introduction of substance in or on is our main term. Where is this happening? The first subterm will be for the epidural space. And what is the actual injection in the epidural space? It's for the steroid, the anti-inflammatory. And here, actually, believe it or not, we don't even have to check the tables for once. That rarely happens. But it gives us all 7 characters, 3E0S. 33Z as the final PCS code. Let's go ahead and take a look at one more example, this time from exercise 17.6 in the handbook. Here we have steroid-induced cataract, bilateral, long-term use of prednisone for chronic obstructive asthma, severe persistent asthma. So here they are saying that the cataract was induced or brought on by this long-term use of a steroid, the prednisone. So let's start with our main term in the alphabetic index of cataract. Subterm drug-induced. That leads us to code H26.3. We know we need to check the tabular. There we need to pull in the 5th character 3 for bilateral. So then we would apply this code, H26.33. Now remember, check for those instructional notes. So within the tabular at category H26, there is also a note, use additional code for adverse effect, if applicable, to identify drug T36 through T50 with the 5th character of 5. So just like that exercise that we had last week, we are going to touch base with the table of drugs and chemicals again. So again, if you're not familiar with this, go back to last week's videos, as we definitely did a quick touch base on that. We will spend a lot of time with the table of drugs and chemicals again later in the semester when we have our injury and poisonings chapter. So right now we're just sort of gradually adding in a little bit at a time, but it's good to get familiar with it and where exactly it is in your book. So again, if you're not familiar with where it is, go back to last week's videos. So when we go to the table of drugs, we find a listing for the prednisone. We will check the adverse effect column, which leads us to code T38.0X5. Again, even though we're not in the index, we're in the table of drugs, we still always need to check the tabular. There we will add the 7th character S for sequela or late effect. This is a late effect of that use of the prednisone or the steroid, which leads us to final code T380X5S. Now that we have the cataract along with the adverse effect from the drug coded, we should pull in this asthma diagnosis as well. So we will start with, for this chronic obstructive asthma, main term asthma, chronic obstructive as the subterm leads us to the correct code of J44.9. Again, check the tabular. There's an instructional note there at J44. Code also type of asthma, J45 category. So again, back to the alphabetic index. Asthma, we know, is severe persistent as the type. Asthma, severe persistent, J45.50. Then we also know whenever we have this long-term use of a drug documented in the record, we should pull that in also as a Z code, as it helps supplement the record when coding. So main term, long-term drug therapy, steroids, systemic. How do we know it's systemic? Again, don't be afraid as a coder to do a little research. Prednisone is a systemic steroid. Take 2 minutes, look it up, you'll easily find this. Z79.52. So we have 1, 2, 3, 4, 5 codes for this particular diagnosis. Have a great week. Happy coding. Don't forget to check in with the Coding Roundtable and post your exercise questions. Have a great week.